sore throat treatment is important because some specific type of sore throats caused by bacteria, which is called streptococcus or beta hemolytic streptococci, can lead on to a heart disease which is called rheumatic heart disease. It is not easy to differentiate, but there are certain pointers which tell us that this is a bacterial sore throat and not a viral sore throat. So a bacterial sore throat would have a higher fever than the common sore throat. It will also have a lot of pain in the throat, so much so that the person finds it difficult to even swallow water. And it will probably last also longer. One important feature to differentiate is that there is no cold, there is no running of the nose, there is no coryza, there is no rashes on the body, there is no conjunctivitis like you get in common cold, which is very prevalent with the change of season. And if the physician examines the throat of such children, there is going to be a pus, a white patch of pus on the throat or even on the tonsils, and the lymph nodes of the neck are going to be enlarged. So if we use all these ways to differentiate viral from bacterial sore throat, I think we will be accurate in 80-85% of cases. So the best antibiotic for a streptococcus sore throat is even today is penicillin. One can give oral penicillin, maybe 250 milligrams 3 times a day for children for a period of 10 days. Some people also believe in giving injectable penicillin, which is long-acting penicillin called penicillin G or benzathine penicillin. Other alternative, especially if penicillin is not available, can be amoxicillin. So amoxicillin is a good antibiotic. If there is any history of penicillin allergy, one can use erythromycin, 250 milligram twice a day. I think important thing is to use antibiotic, that's number one, and number two, to give a full course of antibiotic, which is usually 10 days. Rheumatic fever is actually an autoimmune mechanism by which the body has a reaction to the group A streptococcal infection. So majority of these patients who have rheumatic fever might give you a history of preceding sore throat in the last 2 or 4 weeks, which was bacterial in nature. The classical sign of rheumatic fever is joint pains, and generally it is said that rheumatic fever joint pain is migratory in nature. That means it is present in one joint, and after some time that joint becomes all right and it goes to the other joint.
I had joint pains in my fingers, elbows and knees.
Okay. And it seems that it keeps on shifting from one joint to another.
Usually the pain involves larger joints like knee joints, elbow joints, sometimes even shoulder joints and neck joints also. And there could be swelling, there could be tenderness of the joints, and often these children have so much pain that they are unable to walk. So they don't like to get up from their bed because of so much of pain, and the joints tend to be swollen also. In addition, rheumatic fever can also produce something called carditis, which is basically inflammation of the heart, and that is where I think it leaves long-term damage to the heart by involving the heart valves. Some other features of rheumatic fever could be rashes over the skin, we call it erythema marginatum, some nodules over the limbs, which is called subcutaneous nodules, and rarely some of these patients can present with very abnormal involuntary twitchy movements of the body called chorea, called rheumatic chorea. Fortunately, rheumatic chorea is a late manifestation. Rheumatic chorea and carditis and arthritis don't occur together. There is no diagnostic test available for rheumatic fever, and therefore one depends on something called Jones criteria. So there are 5 major criteria. We call it carditis, polyarthritis, or even monoarthritis, erythema marginatum, subcutaneous nodules, and chorea. And then there are a number of minor criteria, which is fever, long PR interval on ECG, raised ESR, raised CRP. So it is said that if you have 2 major criteria or 1 major and 2 minor criteria, then the diagnosis of rheumatic fever should be considered. So treatment of rheumatic fever is actually very symptomatic. If patient has a lot of arthralgias or arthritis, then one gives an anti-inflammatory drug, and the best drug for such patients is aspirin, simple aspirin. If patient has features of carditis, one may have to treat these patients with drugs like diuretics if patient has breathlessness or has heart failure, or even vasodilators. But the most important part of the treatment of rheumatic fever is secondary prophylaxis. Again, the ideal drug is penicillin. Long-acting penicillin or benzathine penicillin G, as we call it, is given 3 weekly injections. It is a little painful injection. Children don't like it, but that is almost a sure way of preventing further episodes of rheumatic fever, and hence further episodes of damage to the heart valves.